Welcome to this webinar, Peacebuilding in a Health Crisis, Lessons from the Africa Ebola Epidemic. My name is Scott Weber, the president of Interpeace. We at Interpeace are thrilled to be organizing this webinar together with our partners, RUSI, the Royal United Services Institute for Defense and Security, and ECAN, the International Civil Society Action Network. Now, the COVID-19 pandemic has revealed and exacerbated many underlying tensions and inequalities in society that are at the origin of most conflicts around the world. In fact, we need to understand this as going beyond just a health crisis. COVID-19 has triggered a multidimensional crisis, an economic crisis of great proportion. It has threatened the food security of tens of millions of people. It has actually worsened the insecurity of so many people around the world and enhanced conflicts, often triggered and exacerbated by misinformation and by what we call the infodemic that has accompanied this pandemic. We've also seen an increase in human rights violations and a retreat of democracy in many parts of the world where emergency measures are being taken. And of course, we've seen a gendered impact of the COVID-19 pandemic that we need to better understand in order to deal with. Now, more people are likely to die of these other factors than of the virus itself. And that was the case during the Ebola crisis in Eastern DRC and in West Africa, where the response itself was not just conflict-inducing, but actually displaced the medical services and governmental services that were needed to treat and deal with normal problems in society. More people ended up dying of malaria and other diseases than of Ebola itself. So while there's much talk of trying to draw lessons from the Ebola crises of those two regions in order to better meet the current challenge, it's important that we draw the right lessons and not the wrong ones. And that's why I'm so thrilled to be introducing today our two speakers. Seru Kona Garlo from Liberia. She's the senior gender specialist in the Rule of Law unit of the Carter Center in Liberia, as well as being a member of the ECAN network. But Seru today will be speaking on her personal behalf and not on behalf of the Carter Center. And Dr. Nene Morisho, who is the senior researcher and coordinator of the Pole Institute in Goma, Eastern DRC, and a partner of Interpeace. Both of them didn't just live through the crisis in their countries, but they actually contributed to improving the response efforts. And that's why we have such a great privilege to listen to them and the lessons from those two experiences as we think about what is relevant for getting the current COVID-19 response right. So without further ado, let me turn the floor now to our speakers. We will come to the audience about midway through this webinar, and we invite you to put your questions in the question space of Zoom so that we can try to get to them in the second half of this discussion. In the first half, we're going to hear from our speakers. Let me turn to Nene Morisho to begin with. Nene, what are some of the key mistakes that were made, in your opinion, in the response to Ebola in Eastern DRC?
Yeah, thank you, Scott, for your introduction. Thank you very much. And I think I'm going to take, first of all, 20 to 30 seconds to present very quickly the context in which the 10th Ebola outbreak occurred in DRC before I move to the lessons. First of all, we have to know that this virus occurred in a pre-electoral context in areas where the former President Kabila was not really very popular. This is Beni and Butembo. And during that period, there were so many violent demonstrations against against the attempt of President Kabila to run for a third term. Secondly, it's very important also to know that during the Ebola outbreak, the government of Kinshasa decided to ban presidential election in Beni and Butembo, these two districts where he was not popular. And this has generated hunger of the population, and especially, most importantly, the attempt of the population to reject any initiatives coming from Kinshasa. And a third important element we have to know here is that the virus occurred in a context of violent conflict with many militias, many armed groups attacking and killing civilians, the populations. So this being said, what are the major lessons that we can learn from the mistakes that us as peace builders, as humanitarian organizations, we have made during that during the response against Ebola in this part of DRC? And the first one, I think, and according to me, is one of the most important ones, is the community engagement, which must be at the center, at the heart of any response during a public health crisis. Otherwise, if we do not engage the community in the different step of our process, we'll generate mistrust, we'll generate anger, we'll generate violent demonstration as we witnessed it during in Beni and Butembo, and this will undermine the response. So what we know, what we saw on the ground in Beni and Butembo at the beginning of the Ebola response is that the Ebola response team was facing a dilemma between the need to act very quickly and to control the transmission of the disease and the need to engage the population in this decision-making process. Unfortunately, the response team decided to act rapidly in order to control the disease that they didn't succeed to do, and to ignore the community, to ignore their values, to ignore their needs, and especially to ignore their culture. And the consequence, I think, for me was predictable. We generated mistrust within community. They didn't trust the response team, and this really undermined the effectiveness of the response at the beginning. The second element for me, which is very important, is the fact that the care should be decentralized. I think this is very important. And what we saw on the ground when Paul Institute was active on the ground during the Ebola outbreak is that this decentralization of the care, which was decided several months after the outbreak of Ebola, was not only an effective medical strategy because it helped to quickly identify and treat people who are affected, but also it was very important it's a very important tool to gain trust of the communities, and this was one of the most important elements that we witnessed on the ground. Unfortunately, when we started the response against Ebola, the care was centralized in what we used to call at that period the Ebola Treatment Center. And another important element, lesson that we learned from our mistakes is the fact that the response should be built on the existing health system, on the existing health capacities in the community. What we did at the beginning of the 10th Ebola outbreak is to create a kind of a parallel health system, which was only dealing with Ebola and not dealing with other disease. And this was a very big mistake because the population, the local population, they trust their own doctors, they trust their own nurses, they trust their own hospitals. So what we did at the beginning is to create this Ebola treatment center to bring doctors from Kinshasa, from Goma, from West Africa, nurses from Goma, from Kinshasa. And sometimes these people could not even speak the local languages. They could not interact with the patient. And this was a very big mistake. And this has generated resistance of the population, the mistrust, as I said it before. So the decentralization of the care for me is very important when you are dealing with a severe public health crisis in fragile context, like the context in which we worked during this Ebola outbreak. And the last one, maybe 10 seconds, is the role of peace builders, which should be very important during this type of crisis. I think if peace builders are working together with humanitarian organizations, with health organizations, from the preparation of the response, this can help a lot to avoid many mistakes. This can help a lot to make sure that the do no harm principle is actually respected, to make sure that the intervention of other organizations are actually conflict sensitive. So these are some, very quickly, some lessons that us as Paul Institute, we learned from the mistakes that we all made during the Ebola response, which started in 2018 and ended only a few months ago. Thank you.
Thank you, Nene. Indeed, as you're saying, that the crisis, the Ebola crisis, when it hit Eastern DRC, first of all, it wasn't the first time.
Yeah.
That begs the question, why weren't the systems already better prepared to deal with that? But I think the key lesson that you've shared around the mistrust that was created in the response by not engaging communities is one that we find also in the lessons from West Africa as well. We're going to hear that from Seru in just a minute. But also that this wasn't happening in a vacuum. It was happening in a country with multi-layered conflicts already having affected the context, in an electoral period where everything could be politicized as well. And that only made the response effort more complex, but also calls for the third lesson that you said, that the health response be infused with conflict sensitivity, with an understanding of the context, understanding of how it will affect the context. So thank you for that. Maybe Seru, can you build on what Nene said? Where did you see similarities in the response effort in Liberia, and what was perhaps different?
Okay, so thank you for having me this morning, and good morning to all. So, he has touched on some of the I think we have some similarity. Border crisis in Liberia, we have come from a conflict, right? 15 years civil conflict, government and partners are trying to build infrastructure, including health infrastructure and every other infrastructure. And we're in a post-conflict period. We're not informed, we're not engaged, community-wise. So the government and partners try to fight Ebola, but they didn't include communities. So communities, the structures are already set up at the community level. So community leaders and civil society started engaging government and doing a lot of advocacy until the mid of the crisis. Then the government and partner realized, look, we need to get community involved because people were dying. There were a lot of other issues around. So when they got community involved, and we saw what happened, right? The government were able to minimize the spread of the virus. And as that said, so when the virus started hitting and started killing medical practitioners, so it made citizens afraid to go to the hospital with the fear that they will contract the Ebola virus. So people started doing alternative cure for other sicknesses like malaria, TB, HIV, and other illnesses were not getting the kind of attention because everybody was paying attention to Ebola. And what makes Ebola different, the management of Ebola different from coronavirus. When we had Ebola in West Africa, it was in 3 countries, Sierra Leone, Liberia, and Guinea, and it spread to a few other countries, but were not as major as these 3 countries. So international partners and other people were trying to put in funding and resources to coronavirus had hit the whole world to fight coronavirus. including women, seeing women as partners in the fight against Ebola virus. Normally when we have crisis, even during peacetime, the so-called peacetime, women contributions are not recognized. Women are seen as a victim. Women are seen as housewives, the caretaker. So when we have crisis, they see women as victims. Women are not seen as partners in the resolution of the crisis. So it was the same with Ebola. That women were not included until women civil society leaders started speaking out and said, look, we have roles to play. We have the experience. We are on the ground building peace at a community level. Are you trying to, sometimes the way we define peace is sometimes limited by political leaders to the battlefront. They don't see the everyday peace building work that women do and other civil society do at the community level as peace building. So when women request that they should be included, then women were included. And so it took a whole different dimension. They started seeing women issues like the ETU, the Ebola treatment unit, supplies that were carried that were generic. They never had sanitary pad, women-friendly spaces were not created. When civil society women started working with them, then they started creating women-friendly spaces, they started having sanitary pad, and even having messages that would target women specifically. Then we come to the coronavirus. Right now, we have some messages on the negative towards women. So it has been raised by women, civil society leaders, and other groups that look, these messages need to be reworded to be specific, because you can have portray women as the one who are not following the different protocols to prevent the coronavirus. These are some of the messages that they have. Another thing too, we had during the Ebola crisis, citizens did not trust the government. You know, the period of there was the whole issue of fight the president was corruption. So the issue of mismanagement of resources by government officials, acquisition of corruption, being accused of corruption, putting them accountable. Citizens trust into the government. So when the government said, no, this is a trick, another game that doesn't say who needs government resources, citizens did not trust the government.
Saru? Yeah, I think we're having some challenges with the connectivity to Monrovia. I think she's actually dropped off now, unfortunately. It was breaking up a little bit too much for us to get the full richness of what she was saying. Let me just recap a couple things that I think were very important in what she was getting across. One was like Nene said, the importance of community inclusion, but that it was important not just to include communities at the time of the crisis response, but also to be seeing them and their resilience, their ability to be resilient in a crisis as something that you have to invest in far upstream from that. Otherwise, when you get to the crisis moment, it's too late to be doing that work. Two, she talked a lot about and it's related, the critical role of women in making the response a success, that often that is forgotten, avoided, or just not prioritized, and that women play a key role. We're going to come back to the issue of the gendered impacts of this current crisis as well in just a minute. And three, she was talking about the underlying and pre-existing mistrust of the government in Liberia being a real challenge when the government was then expected to be sharing information with the population, and the population didn't believe what they were saying. And so let me actually build on that and turn, while we wait for the connection with Monrovia to improve, let me turn back to Nene on precisely this question. This is something that we've seen as a consistent pattern, not just in the two crises of Ebola in West Africa and DRC, but also now with COVID-19. What I mentioned earlier as being this infodemic, this viral misinformation, as well as the flood of just information in on the networks. People don't know what to trust. They obviously don't trust the formal authorities often. I think that was the case also in DRC for reasons that you mentioned. But in the context of the COVID crisis now, is that similarly a problem? And what are the best ways of dealing with that?
Yeah, I think this is the best thing we have learned from the last Ebola crisis is the communication. We should know how to communicate with people. And now I think the communication and the awareness raising strategies that the government at a different stage, national government, the local government are actually using are somehow effective. You know, during the Ebola outbreak, communication was somehow centralized, and only some people or some organizations were authorized to communicate, to provide information on Ebola. And this is not the case now. Nowadays, we can see that communication is down a different level. Of course, the capital of DRC is Kinshasa, where we have all the national authorities. So Kinshasa is dealing with the national communication as far as the entire country is concerned. But we have also each of our 26 provinces in DRC has also its own communication strategy. For example, in North Kivu province, where I'm based, we have a communication strategy of the province, and at the provincial level, and the governor is in charge of that. When you go again down in the district, you have the mayors who are in charge of communicating with their people. In the villages, you have the head of villages, the chief of villages, who are communicating with people. And this is somehow very, very, very effective, because it's people who know very well the context, who are communicating with their people. And they are communicating in languages that people can understand very well. And this is also the case for the sensitization campaign. You know, what we saw during the Ebola outbreak in Beni, some people who were doing awareness raising campaign could not even speak the local languages. So they were doing it in French, that not many Congolese can understand, especially those who did not go to school. But nowadays, what we're doing is to give the responsibility of communicating to these local leaders. Paul Institute is now involved in a project founded by the European Union. And what we are doing for raising the awareness of the population in villages is to use those local leaders, the youth in the community, those people who are known very well. And we are not actually sending our staff there from Goma to Beni, from Goma to Ruchuru, from Goma to Masisi to conduct sensitization. And it is actually working very well. And what we saw, for example, at the beginning of the outbreak in March this year, is to see the extent to which the populations were really very, very keen to adopt the barriers measures, even before these measures have been imposed by the government. I was myself really very astonished with that. We saw people starting to buy their own masks. We saw organizations buying masks for their staff. We saw people washing hands. We saw people banning to shake one's hand, etc. So I think this could be due to the fact that awareness raising is done by the population, by the people that the population knows very well.
By the people that the populations trust.
That the people that the population.
The red thread theme throughout this entire conversation is the word trust.
Yes, trust.
As we've learned in our own work with you in Eastern DRC and elsewhere, we've worked in Liberia too, people do not trust information. They trust sources of information.
Exactly.
And what you're talking about and what we found to be the most useful strategy is actually identifying in communities the people in whom everyone trusts, and then getting those people to be relaying the science relaying the messages to their own co-citizens and fellow villagers at the local level. And so it's really, the thread around this is really about trust, including with the misinformation. I want to come back and turn to Seru, who's back with us now. We're keeping her camera off just to privilege the quality of the sound. Welcome back, Seru.
Thank you so much.
I wanted to touch on something that both of you have hinted at, which is that ultimately, if we're going to have a trust focus in the response, having that be front and center in terms of what we have learned in the past works best in terms of getting the communities to buy in to these response efforts, if that needs to be at the core of the response effort, then that ultimately challenges quite significantly the current model of international assistance, which is still based on quite a top-down approach. Nene talked about the challenge of the need to go fast rather than to actually engage the communities, as though, I mean, I would say that's a false dilemma, that engaging communities doesn't need to be something that's very lengthy and time-consuming. Even if it does take more time, you ultimately get to the destination better than if you rush and go in yourself. But that's a very top-down kind of emergency response culture that has created that. I know in talks with you, Seru, and maybe you can say a word on this, is that many of the international actors that got involved also carved up the country in terms of zones of where they would take the lead in those areas, and that it became a little bit of almost like a power grab, a power game between the various actors. Maybe you could say a word on that, about how the model of international assistance to Ebola was part of the problem.
Thank you, Scott. So, okay, so in the so-called normal times, we all know when we have international organizations come to intervene, come to assist country develop, people select areas of regions that they want to work in, that they feel comfortable to work in. And the communities and the citizens get used to those organizations. They know Carter Center, they know RX, they know the different organizations, they build relationship. So in time of crisis, they expect those organizations to come back to work with them. But some of those organizations don't have the experience in emergency. So now the partners will have to go around the table to see who is operating where, who can give assistance in times of crisis. So sometimes while they're making those decisions, communities are left alone, communities are left vulnerable because they expect the traditional donors to come back to work with them. And some of the traditional donors don't have experience in emergency. They are not health workers, right? They're not health practitioners. So the time interval to get the experience, deploy the different qualified staff, deploy different staff, get the correct messaging. I mean, a lot is happening at the community level. Communities sometimes take charge of those, take charge of the activities and try to do their own intervention before they get the right messaging from the government and partners. Sometimes they have some positive and negative impact. So it's kind of, for now that during the coronavirus period is quite different. During the Ebola was strange, the government was not prepared for it. So the messaging was conflicting. We never have correct messaging from government. Everybody was having their own kind of messaging and all of that. But now it's different. Now the government recognizes that they have the traditional leaders, they have the town criers, they have women leaders. So the messages are going directly to the community, and the community leaders are using the messages to get community involved. But we still have the issues of government, of citizens not trusting the government, because right now we have a lot of issues with the governments. People have a lot of issues around transparency, accountability of resources. We all know the $16 billion case, the LeBron that got missing, no accountability. Now you come to say we have a coronavirus, and people don't see people dying from coronavirus in the community as Ebola. During the Ebola crisis, a lot of people die in the community. Community members had to call the ambulance to come collect bodies, to collect sick people. But right now, we don't have to come to our community and somebody is positive of coronavirus, or someone died, and the government did a swab, they did a test, and come back to the community and say, look, the family member died of coronavirus. So the communities observed 14 days, 21 days, and nobody in the household come down with the virus. Now, for me, what needs to be done, the government needs to come back in the community and say, probably somebody here is symptomatic, spreading the virus. They don't do tests of people who don't show signs. So then what is happening? It also helps to add to community mistrust of the government that, look, we said my relative died from coronavirus, but nobody in our household, nobody in our community have died. So the issue of trust, how can the government build citizen trust? I think they need to include the citizen, include community in such a way, as I always say, in pre-crisis time, build trust, pre-crisis time, then we have crisis, community will just move on. Community will believe and accept the information that will be given to them during the crisis time.
Right, thank you. And you're essentially calling for an investment in community resilience in normal times, like you say, so that they are better equipped to be able to deal with these crises when they come. I mean, it reminds me of the saying that you fix your roof when the sun is shining, not while it's raining. And yet much of the investment in building up capacities or enhancing national agency to deal with these things is often linked to emergency response. So again, you're just reinforcing the point that the models of international assistance, which are focused on response, not on prevention, which are focused on fragility and not on resilience, are actually contributing to this perpetuation of risk. And so we really need to rethink these models. There are some very positive, I think, examples that you've both been citing from Liberia and the DRC, where lessons from what happened during the Ebola crisis have woken up the various actors, be it the government or local communities, to the importance of them actually taking the lead on the ground in their own response. That is a very positive development. Again, that calls into question the previous models. So that's very good. Let me turn now to the section around Q&A, where the audience online has the opportunity to actually post questions in the space. And I want to take up the first one that deals with the fact that the COVID virus, as we know, can be carried and transmitted by someone who is asymptomatic. And unlike the Ebola virus, where you got sick and passed away because it was even more lethal than the COVID virus has proven to be, it was more immediate. And so you were able to actually see the consequences of the infection in real time. Here, anyone could be a threat. And so my question to you is, in a context where mistrust, not just of government, but also social mistrust, horizontal mistrust, if you will, is already very strained, have you seen this invisible threat actually exacerbate social tensions and social cohesion in your countries? Nene, maybe we can start with you.
Yes. As far as relationship between or among communities are concerned, not yet. So far, we can't really see the social impact of the COVID-19, but the economic impact, we can see it already. But the social cohesion issue is raised when the population, in the relationship between the population and the government, and especially with the police officers who have to enforce the law. As you said, this virus is quite different from Ebola virus because an asymptomatic person can easily transmit the contaminate other people. And this is why the government is obliging people to respect the barrier measures, and especially to wear to use the mask. And this is what is generating somehow the conflict between the youth, the young people, and the police officers, because very often young people do not comply with this measure, do not respect the measures, and the police want to enforce the law. And in Goma, for example, we witnessed some violent conflict between youth and police officers, which ended in the death of 2 police officers. So I think the problem so far in DRC is still in the relationship between those who are in charge of enforcing the law and the population, especially the young people who are not really very keen to comply with these barrier measures. And as I said it before, at the beginning of the outbreak, almost everybody was really keen to respect the measures, but there is a kind of fatigue of the populations. They have to go out, they have to use buses, they have to use motorcycles in order to earn their life. And yes, they have also to face the police officers who want to enforce the law. But very often, the police officers also use violence in order to enforce the law, and this generates violence between the 2 groups of people. But what I can say so far, we are not witnessing really a social impact or the impact of COVID-19 on the social cohesion, on the relationship between communities. And we don't know. We are still in the outbreak. Yes, but we close our fingers and hope that it will not happen.
That's very encouraging. In West Africa and in the Sahel region, we're starting to see the stereotyping of certain groups, especially peoples of with a more nomadic tradition, are being accused of being spreaders of the virus because of their movements and networks. And it's very good to hear that that's not happening right now in Eastern DRC. Cyril, what about in Liberia? To what extent is the invisibility of this current threat actually harming social relations?
So within community, I think there still exists social cohesion. People trust one another, but it has to do with community A resident traveling to community B resident. I remember we had an incident where law enforcement officers left Monrovia and were going in Southeast Liberia, where the government had imposed curfew and said there was no eternal travel. Well, a law enforcement officer left Monrovia and went to Southeast to Grand Judea County, and the citizens rejected that he should quarantine himself for 21 days before it brought tension. It brought tension, and he had to abide by the citizen regulation because it was from the government, right? So, but within communities do have social cohesion, they understand each other. I mean, they respect each other. Even some communities have washing hand buckets and soap. And before you enter the community, you make sure you wash your hand and make sure you wear a mask. But again, I always say and observe that fighting an epidemic, the coronavirus, if you want the community and you want the country to succeed, it has to be the leader. The leader of the country has to set example. You can say people should wear masks and everybody should be in by 6 o'clock. Then the president is now wearing masks. Government officials are having party. They're not keeping social distance. Then where do you send a bad signal? People have social media is available. People show you pictures. How would they say we should wear masks and they're not wearing masks? How did she say we should be in by 3 o'clock and we see they're having party at 3:30? So what is the relationship, right? So if you want to fight a pandemic, anything you do, especially in our country, Liberia, we look up to our leaders. Our leaders set example. When the leader is moving right, everybody will follow the leader. But if the leader is not moving right, everybody will follow the leader and people will not move right. And you have few people who are trying to set good example. People don't look up to them. People look up to the leaders. But at the community, there are cohesion. Even the chiefs, the elders, those are people who hold a tradition and value. People listen to them, who have town criers, carry on messages, telling people how to protect themselves and start spreading the virus.
Thank you, Cyril. You talked earlier before your mic cut off about the important role that women play in the response effort. And I want to come back to that, both from the perspective of the agency that women bring to the response, but also the gendered impact of COVID as well. It's had a disproportionate, unlike the Ebola virus, which had a disproportionate impact on women who were the primary caregivers and got infected to a much greater degree than men. With COVID, it seems to be the inverse, that more men are being severely affected by COVID than women. That's one general kind of finding, but I would like to hear from both of you about how COVID has been is having that gendered impact. And the second question is also about the gender-based violence that seems to be on the increase also during this crisis with the lockdowns in place and other measures that have been taken. We've seen an uptick in the domestic violence and sexual-based violence in all around the world, actually. So maybe Seru, you can speak to both of those issues.
Okay, so thank you. So for the coronavirus pandemic, when the first case was reported and the government identified a newly constructed 14 military hospital, right? So they didn't create spaces that are friendly for women and children. So they have all the rooms and everything there was generic. So if a woman got ill, she went there. But they didn't take into consideration that a woman with 5-6 children who get affected by the virus and she'll be taken in there, she's a single mother. What happened to her children? Who takes care of her children? There was no system put in place. You carry her to the treatment center. What happened is she having sanitary pad, right? She having her traditional clothes. If a traditional woman, she wears her traditional clothes, now you're going to give her a European or an American hospital gown. Is she going to be comfortable in that? So they didn't take all of those into consideration until Civil Society Women started huge advocacy, and they're working now with UN Women, UNICEF, and other local groups that they had to build a care center for children of women that are affected by the virus. So the children are there taking care. Every now and then you see in our chat room, they'll be asking for food for the children, asking for different supplies and that. So in terms of, I always say in terms of peace prepare, get women involved, bring women to the table. When we say table, I'm not talking about a regular peace table where you have the rebel leader. No, in a community, bring them, they have views, and the views are very important, include them. If you have crisis, then you automatically bring them to the table to talk, so you hear their views. So right now, when the crisis started, we had a lot of domestic violence just went on the increase, because women who normally leave early in the morning to go to work or go to the farm or go to the business center were home. They had to rush and come back home, and they were home with some of the abusers. So domestic violence just went on the increase with beating, rape, sodomy. I mean, you just name it. Well, I was just listening to the radio this morning. There's a case of a man who raped a young child multiple times. So now partners and government are setting up hotlines where those cases can be reported. But if they report those cases, our judicial system was never prepared before the crisis to handle and rape cases and other crimes against women. Were never prepared. The infrastructure was never there. So are they going now to be able to respond adequately during crisis time? No, they were not. And perpetrators will just go scot-free, because in normal times, so-called normal times, they were not able to handle those cases. They were not able to bring perpetrators to book, when they won't be able to do now. So these are some of the challenges that we are faced with. Prepare the ground, include women, bring them on board. If you have crisis, it's automatic, you bring them, but don't always see women as victims. That's the mistake. Women have always been seen as victims. Or you go back to your normal, your traditional roles. You are victim. After everything, we'll take care. You know, women have contributions to make. They always make contributions. I don't know why people forget. Democracy is never complete until you have women on board. That's the enemy of the society we live in, the exclusion of women in participating in all of these different sectors. Thank you.
Thank you very much. Nene.
Yeah. Yes, I'm going to focus mainly on the impact of Ebola response, on gender impact of the Ebola response. And I'm going to talk about two major issues that we witnessed on the ground. As a social scientist, I was really very interested to see how women, how young girls, they were impacted by the Ebola response. And first of all, what we saw on the ground is the fact that is the behavior of some people coming from outside of Beni when they are recruiting staff. We had so many testimonies on the fact that some girls, some women, married women, they were obliged to have sexual relationship with these people working from the response in order to get a job. And this was one of the big issues in the community there. And this was one of the big factors, one of the major factors explaining the conflict between the response team and the community. The second thing that we saw on the ground, on the field, is the higher rate of prostitution. The prostitution rate increased very rapidly during the Ebola response due to the lot of money which was injected in very small cities like Beni, like Butembo. These are very small cities, and there were millions of dollars which were injected there. As an example, I can give you some example. Doctors who were imported from Kinshasa to Beni, they were paid $100 to $150 per day. Can you imagine in a context of Beni? While local doctors who were working for the response, they were only paid $10. So this was a very big issue due to a lot of money circulating in the economy. And this was the factor explaining the high rate of prostitutions. We had also a discussion with a local doctor who told us that during that period of 2 years, there were so many unwanted pregnancies for young girls. We have also heard that we do not have facts to confirm that the rate of HIV increased a lot. So I think these are issues that need to be very well investigated by researchers. But what is quite clear, and this comes from one of our staff who is based in Beni, is that I don't know how to call it in French, les conflits conjugaux, to call it in English.
Domestic
conflicts.
Domestic
Yeah, exactly, marital conflict. The rate of marital conflict also increased a lot during that period. So I think all these are mistakes that were made by the response team. And yes, once again, unfortunately, women and young girls were the major victims.
Yes, thank you. So we have about 10 minutes and I want to take a few more questions from the audience. There's one colleague online who just reinforced the issue about the relevance of the manipulation that you were talking about in Congo being possible also with a future vaccine for COVID. The distribution of the vaccine, when it does come, there's a potential for that to become another leveraging tool for sexual abuse, basically. Yeah. In places like the DRC. So I just wanted to make that point that the colleague posted online. But then to come to another one that relates to the fact that, and we saw this working in Eastern DRC, is that to the communities in Eastern DRC, Ebola was not the top priority. It came as, I don't know, number 4 or 5 on their list. They were worried about eating the next meal. They were worried about being able to farm in the fields and not getting killed or hurt by the roaming armed groups. The sexual violence that's a daily curse for women in Eastern DRC, et cetera, et cetera. They had other malaria, which kills far more people than Ebola. And so it was seen in Eastern DRC, in our experience there, as a Western priority. Mm-hmm. And in Liberia, I want to hear from Seru if it was seen that way too. So if it is seen that way too in terms of COVID now. So what does this mean for the already quite weak trust between international actors and local communities. Do you see the COVID-19 crisis as exacerbating that tension between the prioritizations of the outside world and the local priorities? Maybe let's start with Cyril.
So initially when Ebola started in Liberia, yes, people thought and assumed that it was a Western thing. It was never existing. So they were never going to adhere to all the different health protocols that were listed by the government international partner. The conspiracy theory that someone invented Ebola in the forest between Guinea, Sierra Leone, and Liberia to create vaccines so the Western world could get rich. All the different theories, all the different assumptions were there. So it also helped to derail citizen trust in helping to fight the virus. But when people really started dying, and people started seeing the sign and symptom experiencing it, then communities said, look, we need to do something. This is real. We need to, and that's when communities step in. With the issue of the coronavirus is kind of different in that a lot of people not dying from the virus in the community as with the Ebola virus. So yes, people still feel that the whole thing about coronavirus is not for Liberia, it's not for Africa. In fact, we suffer from cold. We have other illnesses that are killing people, malaria, tuberculosis. We have the issue of women trying to pay back loans that they took from the bank to do their businesses, and now you impose curfew. So the priority, people have different priorities. You tell people about wearing masks, to buy masks, they don't even want to buy masks because they feel that the $50 or $100 they're going to Liberian dollar equivalent to maybe like 50 cents US, they're going to take to buy face masks. They can buy and sell 2 cups of rice, right? So the issue of water, you need to wash your hands constantly with water. We don't have running water. You have to buy water. You have to stand on long queue. I was talking to, we were writing an article, I was interviewing some women in my community, and the women said, look, how will I stand, keep social distance? I have to fight for my space to be able to carry my jerry can to the water, to the pump, and be able to pump water. Who is standing at the pump come to pump water? So how can I wash my hand? So I prefer getting the water to drink than to wash my hands. So there are other priorities that the community have above coronavirus, because they don't feel the kind of impact the virus have on them physically, but they feel the secondary impact of the virus, which they consider to be primary for them, the economic hardship that the virus has imposed. Right? When we had a curfew.
Many communities have been saying, have been saying to us that they prefer to die of the virus than of thirst or of hunger.
Exactly. So right. You see, people have to. So that's the situation we are faced with. And the underlying factor is not allowing community to take charge and take responsibility of their well-being all of the time. We always want to give handouts, and we should not be giving handouts. So people in able communities, creating an environment where communities are prepared. You're not telling any community say, I'm coming to your community to create awareness. They will hear the message on the radio, they will hear it to the leaders, and they will carry it forward.
Right. Thank you. Now, Nene, in the epicenter of the Ebola crisis in Eastern DRC was the region in Katwa, Butembo. That became the epicenter not just of the crisis of the virus spreading, but also of the violence around the response and this mistrust of the international community. And one of the things that we discovered by working there was that there had been a long history of poor interventions by the international community in that zone, what they've been calling the Katwa affair of the 60s. And that is alive in the minds of the elders of that area. And they told the young people, remember back the last time we had an invasion from the outsiders in our area. So there was already a deep mistrust, layer upon layer of mistrust of international intervention. And then came this priority of Ebola when people were dying of other things, that the local community didn't understand that prioritization. Why hundreds of millions of dollars were being spent on this when we've been dying every day? Where were you when we were dying of these other things?
Exactly.
Was the reaction?
Exactly. Exactly, and that was the big problem during the Ebola response in Beni, in Katwa, in Mabalako, in Butembo, etc. These are people who were dying on a daily basis, killed by armed group, by militias, the insecurity. I think the big problem of the 10th Ebola outbreak in DRC is the context of security in which it has occurred, because the population on the ground, the field was saying, what? We have been suffering here for quite a long period. We've been killed several times. The MONUSCO is just at the corner there, and these militias are killing people here. We don't understand now. At the beginning, they used to call it this small disease. You are coming with millions of dollars. We don't know exactly what we want for us. And the situation became, again, worse when they started to talk about the vaccine. So, the rumors about the vaccine, they started saying that you want to kill the populations. I think, yes, I totally agree with you. For that populations, the fact that they've been ignored for quite a long period by the international organization, by their own national government, did not really help the Ebola response when they come with millions and millions of dollars in order to fight the virus. So for them, the priority was not Ebola. The priority was to secure their villages so that their women, they can go themselves to do their farming work. And yes, that's what I can say about that.
Yeah. Well, thank you. I think we're going to need to wrap this up. We have about a minute and a half. And let me just, I'm not going to try to summarize all the richness of what you've shared, both of you, but I do want to kind of underscore a couple points. You've talked a lot, and I think that's the red thread of this conversation, is the issue of trust. Is that one, we have to understand that when a virus like COVID-19 or the Ebola virus, when they affect countries like Liberia and the DRC, they are intervening in a way in a context of deep conflict, of mistrust, of already so many other challenges that it's just one additional stressor in the lives of the local people. It is not necessarily their priority. And so it's very important to align the response with the priorities of the local communities. If they don't see it as a priority, they're not going to buy in to the response. And if they don't buy into the response, it won't work, as we saw so painfully and unfortunately at a great cost to loss of life in both of your countries. So that's the first thing, is that trust is critical. And that relates also to the way that the response is done in terms of information, in terms of decentralizing the effort to build on the existing infrastructures, even if they're weak, the existing infrastructures, health infrastructures, governance infrastructures, that people know that is much more proximal to their lives and that they can relate to, rather than importing or parachuting in people from the capital or who don't even speak the local languages. So it's the proximity, it's the familiarity that breeds that trust that is so important. And that calls into fundamental question the mode of response of the international community in these contexts that tend to be, like you said, Nene, very focused on the go fast, rather than take your time to engage. And I think, again, that's a false dilemma. Community engagement does not necessarily need to take a long time, and yet it gets you to your destination better. So the idea of rushing slowly is an important one in this context, but also the top-down centralized approach, when what you need is actually a much more, not just bottom-up, but horizontal engagement in communities, by communities, as a key part. And that's going to challenge a lot of the international community's modes of operation, the way things are funded. If it comes very much in support of the push for more localization in international aid that we've been hearing about, but that we have not seen realized just yet. We have talked also about some very positive examples of community resilience that you've both cited, that learning lessons from the Ebola crises in your countries, as COVID hit, communities were ready to organize themselves. They had learned lessons about how to generate information themselves, how to share that information, how to mobilize their communities. But that there's also the danger of the fatigue that we're seeing all around the world around the COVID crisis. So making sure to continue to invest in that, in those sources of community resilience, what Seru talked about so eloquently, about the need to focus on investing in those capacities in normal times too, not just during a crisis, is really one of the take-home messages of this webinar. We are still too much focused on an emergency response mode of investment in agency and capacity enhancement, and that is part of the problem. So really building on that type of local resilience in good times, you fix your roof when the sun is shining, is one of the take-home messages of this panel, I believe. So let me say a big word of thanks to our two speakers, Seru Kona Garlo, the Senior Gender Specialist at the Rule of Law Unit at the Carter Center, speaking on her personal behalf, though, and Nene Morisho, the coordinator of Pole Institute in Goma. Thank you both for sharing your insights with us. I think our listeners and viewers will have benefited greatly from that. And I hope that these lessons do shape the current COVID-19 response. And let me thank, lastly, our friends at RUSI and at ICANN for the collaboration in doing this panel together. Thank you so much, and go well.
Thank you for having me. Bye.
Thank you, Seru. Bye.
Thank you, Nene.
Bye.
Nice meeting you.
Thank you.
Bye.
Nice to meet you too. It was a pleasure. Bye.